Without understanding the nature of pain and trying to address the pain is like throwing spaghetti at the wall and seeing if anything sticks. You may get lucky with the spaghetti, or worst case scenario, you would just dirty the wall a little bit. But with this spaghetti approach applied to pain management, both you and your patients and their families have a lot to lose. You're listening to Pedia Pain Focus, episode number 80. And today, I'm talking about why we need to stop treating pain as a symptom of something else. So, stay tuned.
Pedia Pain Focus.
You're listening to Pedia Pain Focus, brought to you by Proactive Pain Solutions. Pedia Pain Focus highlights pediatric pain information and provides tools and resources for all healthcare professionals taking care of children dealing with pain. Here's your host, Dr. Anjana Kundu.
Hey there, this is Dr. Anjana Kundu, your host for Pedia Pain Focus, welcoming you to another edition or another episode in the month of September, which is the Pain Awareness Month. And today, we're talking about why we need to stop treating pain as a symptom of something else. And you might say, this is crazy. Why are you talking about it in episode 80? Why did it take you so long to talk about this concept? And what do you mean? Well, I know it's a bit crazy that I'm talking about it, this very basic concept now, and some of you may think that this is basic and may be wondering, then why am I talking about it? Well, let me tell you, there are people out there that need to hear this. You know, as my guest, Dr. Eccleston said, just because we, those who do pain all the time, pain management all the time, we spend all our time talking about or thinking about, especially for our cases, pediatric pain, that doesn't mean that everyone else is doing the same. As a matter of fact, we are the minority. So what may be so obvious to us, those of us who do pain management, be it pediatric or adult, we may know this, we may think this is basic, but a majority of people out there may not be as aware, as tuned in, and this fact may not be as apparent to those people that are not consumed by this work that you and I are doing all the time, every day. However, it is important. Actually, I should say it's crucial that we all understand, that we need to understand when is pain a symptom that signals attention to any underlying etiology versus when pain is the etiology. That understanding will help with the why, when, and how we all approach pain presentations of our patients accurately and effectively. So, here we go. Let's get started. We all know that pain is a major source of suffering, distress. It interferes with daily functioning physically as well as emotionally, and it often results in significant disability. So that is a fact that you know, you've heard me say that over and over, you've heard all my guests say that over and over. There's enough literature that suggests that. Pain is also one of the most frequent causes for patients of all ages to seek medical care. And as a matter of fact, up to 80% of children presenting to the ER have pain as a major component of their presentation. And you don't believe me? Well, you can look up the literature yourself. However, you can also listen to episode number 78 with Dr. Samina Ali, who is an emergency medicine physician, a peds emergency medicine physician, and a pediatric pain physician. Anyway, back to today's episode. Despite these figures, increasingly, I'm realizing and recognizing that even at this stage, despite major advances in understanding neurobiology and science of pain, with this paramount literature that's out there about the impact and burden of pain, even to this day, pain remains misunderstood, it remains under or unassessed, and certainly it remains under ill or untreated, especially for the at-risk populations, which are the children, the minority patients, the ethnic groups, and even elderly for that matter. Till date, there are myths and misconceptions that cloud the healthcare professionals' clinical assessments, impede the quality of care that they provide for their pediatric patients who face pain issues, despite having their best intentions to do otherwise. As a matter of fact, I would say one of the biggest misconceptions and myths out there is that pain is a symptom of something else, that it's a byproduct of or associated with another disease, trauma, surgery, etc., instead of being recognized as an independent entity in itself. So obviously that raises the question, why would that happen? Why is that the case? Well, for starters, historically, we are simply taught about the Cartesian model of pain, wherein pain is the body's way of telling us that there is an injury and that we need to do something about it to ensure that healing occurs and that further injury stops. So, for example, you've all heard about or read about and seen this picture, this image of a hot surface, a hand or a foot touching a hot surface or a fire, and suddenly there is a reflex that's set up and you withdraw your hand, your foot, whatever part of the body that's exposed to that hot surface. That is basically graphic representation of this Cartesian model of pain. So we're taught that once you remove that source and once you allow that to heal, then things are better, and that's that. So pain is a result of exposure to this noxious stimulus, this trauma, this injury, this heat, and we know what caused the pain, and once we give it enough time, once we remove ourselves from that situation, and once we give it enough time to heal, then it's all better. So pain is a symptom and secondary to that event. So therefore, what we're always doing when we're looking at pain is looking for evidence of that very insult, injury, or trauma, or that event. And when we don't find it, we either dismiss the patient's complaints or we feel at a loss to explain why our patient is still experiencing this pain when there is no evidence, no identifiable evidence of that injury that would explain this kind of response. So that then ends up casting doubts in both camps for the patient as well as for the healthcare professional themselves. And needless to say, this doesn't serve either one of the parties. Now, another big reason is that despite the fact that we all know and understand that pain reports as well as pain experiences from the same type of degree of injury or surgery varies from person to person. So the response from that person or how they experience that pain will be different. Then rather than considering the complexity of that pain, which is explained by the biopsychosocial model, it is often falsely attributed to a patient's attention-seeking or medication-seeking or some other secondary gain that they may be looking for. So that becomes the major explanation. Again, this does not serve either one of the parties appropriately, because once you start looking at that and miss the actual reason or the bigger picture, we don't tend to do justice for diagnosis and therefore not for the treatment, and therefore the outcomes are terrible as well. Now, I can understand how it may be clear as mud as to why it's not easy to put pain in its own independent camp as an independent identity. We see pain as a component of many acute and chronic illnesses like appendicitis, pancreatitis, sickle cell disease, complex regional pain syndrome, arthritis, so on and so forth, right? So we've got all these different presentations, different illnesses, different diagnoses that have pain as a component. But who says that it can't be both? Meaning, it may start out as a symptom of one of these diseases, but then later can evolve into an independent entity or a diagnosis in itself. That's the sight we often lose. So we're often still looking for that explanation of another disease, another process to explain why our patient is feeling that pain. Whether the pain starts out as a primary process by itself or as a representation of the other disease, in either case, pain, and especially chronic pain, requires a much better understanding, and often it also requires special treatments and care for that matter. As I often say, not all pain is created equal, so why should we be using a single lens to examine it? We should be examining all facets of pain. In this instance, and for the purposes of this episode, I'll talk about the differentiation between acute and chronic pain vis-a-vis the classification of chronic pain, acute pain, just pain in general, and also discuss when pain is a symptom or maybe a signal of something else that's wrong, and when it is actually a disease entity in itself. So let's first start with the classification and different types of pain in general. So everyone knows there is acute and chronic pain. So the classification of pain actually can be based on a couple of different factors. One, like I said, acute and chronic would be mostly based on the duration. So pain can be classified based on the duration or the location. So you can talk about pain that is located in your head, the headache, the abdominal pain, the backache, the musculoskeletal pain. Or it could be classified based on the mechanisms of pain, which could be nociceptive pain, which is further divided into somatic pain or the visceral pain. Somatic pain is related to injuries, illnesses that involve bones, muscles, ligaments, etc. So for example, you're talking about back pain, neck pain, chest pain, which is the costochondritis, pleuritis, osteomyelitis, etc. So those pains fall into the somatic pain. Then there's the visceral pain, which is due to injury or insult to the internal organs. For example, we see the pancreatitis, appendicitis, cholecystitis. Then we have neuropathic pain. Neuropathic pain is pain that is initiated or caused by or is a result of a primary lesion in the nervous system. And that can be peripheral neuropathic pain, which basically occurs in the lesions that happen to affect the peripheral nervous system. Example, the complex regional pain syndrome or peripheral neuropathies. Or it could be central pain, which happens when the lesions are affecting the central nervous system. Example would be pain that happens after strokes or ischemic injury, or some of the kids with anoxic brain injuries might be experiencing pain. Or pain could be related to cancer. So these are all the different mechanisms that help us also create this classification. Another way to classify pain would be non-malignant and malignant, which is basically based on the etiology. So based on the etiology, malignant pain obviously is cancer-related pain, so that can go in here as well. And non-malignant pain will be all this other chronic pain we've talked about. And most of the times, we take these factors into consideration, but most of the times the way we think about pain is mostly in terms of acute pain and chronic pain. So let's focus on that primarily. So acute pain is pain that comes on suddenly and lasts a short time, and there is an identifiable onset and resolution. There is often a identifiable injury or source of trauma or surgery, what have you. And this pain typically resolves with the resolution of that source of injury, insult, and when enough time is given to heal it. Typically, acute pain also is what signals that something is wrong, so we initiate our protective responses and allow that healing period. Acute pain involves, obviously, the source of injury, which then results in peripheral and also to some degree central inflammation, but that's limited typically. And there's activation of the nociceptors, which carry these signals. And obviously the whole pain pathways are activated. However, as I said, that whole process is limited. It is identifiable, there's evidence for that, and when that heals, all these inflammatory mechanisms in the periphery as well as central nervous system go away. And therefore, our treatment plan obviously is targeted at helping those mechanisms to resolve. Whereas chronic pain, on the other hand, is pain that lasts more than 3 months, although there are some exceptions, and so it's not an absolute rule, especially for when we're talking about neuropathic pain. So there are certain pains that you can have those features of chronic pain right at the onset. So you don't need to wait for the 3 months to pass. So if it's a neuropathic pain like complex regional pain syndrome, you address it right away like you would address the chronic pain. So chronic pain persists despite the resolution of the injury. So the evidence of that insult and injury is gone. Therefore, there may not be any identifiable etiology or pathology that we can point to, that we can show and demonstrate by any tests or radiology or anything. And this chronic pain typically gets propagated by changes in the peripheral and central nervous system, but mostly in the pathways. The signaling is what's altered. That means the major mechanisms that are involved in chronic pain include chronic, low-degree, non-identifiable inflammation. So that's a hallmark of, or the explanation for chronic pain is inflammation, even when there are no, not yet anyway, identifiable biomarkers for that inflammation. In addition, there are changes that occur in the membrane permeability at the nociceptors and the expression of the voltage-gated channels. There's also recruitment of the neighboring nociceptors. So the nociceptors that were previously carrying other signals or responding to other stimuli are now basically getting busy transmitting pain signals. So some of this evidence is seen. So if you look at acute injury, if there's a cut or a bruise, you'll see there's the area of the cut, but then there is surrounding area that gets erythematous and also painful. That is evidence for recruitment of the neighboring nociceptors. But again, we're talking about that in acute injury, right? In chronic, those cues of that cut, that bruise, that inflammation, that swelling, all that is gone, and yet those nociceptors continue to do the work of the pain nociceptors, basically. Another mechanism is long-term potentiation of the dorsal root ganglion and central sensitization that occurs. Again, this is basically what's happening is what normally would stop after the healing of injury, those signaling continue to happen and continue to amplify the pain signals and keep sending those pain signals to the brain. That's what both these terms really translate to, the long-term potentiation of dorsal root ganglia as well as central sensitization. Basically, it means that there are ongoing pain sensations that are being transmitted despite the failure of identifiable noxious injury or evidence of injury. And finally, another very important and key mechanism is a failure of the inhibitory modulation of pain. So we know we have the ascending pathways that take the pain signals to the brain, and then we have the descending pathways that act as the inhibitory mechanisms that modulate our pain so that we don't continue to constantly feel pain. In cases of chronic pain, there's a failure of that inhibitory modulation, or it just weakens. So you're not getting the same degree of modulation that you would get in the normal circumstances. Ultimate result of that is this ongoing pain without any evidence of injury, inflammation, or anything. For that reason, chronic pain is defined as the pain that persists. Duration, like we said, is 3 months, but there are exceptions to that. But in chronic pain syndromes, pain can be a sole or a leading complaint, and it typically requires special treatment and care because those evidence of injury and inflammation are gone. They've resolved, yet there are mechanisms that have been altered in the very software of our brain, so to speak. If you want some more ways to better explain and understand pain, then you should definitely listen to my podcast about metaphors, and I will link that in the show notes. There was a task force by the International Association for Study Pain, which is considered as the very authority on pain, as well as the World Health Organization, that worked between 2012 until 2018, when in 2018 they released an updated classification that reflects the true complexity of pain and pain classification. And that was reflected in the updated ICD edition, ICD-11. There, pain is not only described as acute and chronic, but specifically for chronic pain, there are particular diagnoses based on the classification. And how's that classified? Chronic pain is now further classified as chronic primary pain and chronic secondary pain syndromes. And this is where it basically defines when pain is an independent identity to begin with versus when pain starts as a symptom but then becomes an independent entity and diagnosis in itself. So what are the conditions where chronic primary pain happens? In these situations, pain is conceived as a disease in its own right. It's defined as the pain in one or more anatomical regions that persists or it reoccurs for longer than 3 months, and it is associated with significant emotional distress or functional disability, which means that it interferes with activities of daily living and participation in social and normal functional roles. And that cannot be better accounted for by another chronic pain condition. So it is a primary sole condition in itself. So you can't attribute it to something else, which then if you're going to attribute it to something else, that is kind of by definition the chronic secondary pain, which we'll talk about in just a moment. Now, this chronic primary pain definition is a newer definition, and it's applicable to chronic pain syndromes that are best viewed as health conditions in themselves. For example, the chronic widespread pain that we experience in cases of fibromyalgia, complex regional pain syndromes. There's also chronic primary headaches and orofacial pain. So the migraines or TMJ dysfunction disorder, those fall into the chronic primary headache and orofacial components, as long as, they're not developing secondarily, which they could be as well. Chronic primary visceral pain is another type of primary pain, which is often seen in irritable bowel syndrome. And then there's a chronic primary musculoskeletal pain, which is basically your non-specific low back pain that sometimes you just don't find any other etiology to explain it. Now on to chronic secondary pain syndromes. Those are linked to other diseases as the underlying cause. And for those, the pain may initially have started as a presenting symptom, but then subsequently, the pain has become the major player and the hero of their presentation, or I should say villain of this presentation, because pain is never a hero, right? We don't want it to be a hero. And it's that point that marks the stage when chronic pain becomes a problem in its own right, in its own existence. When the chronic pain continues beyond and despite the successful treatment of the initial or underlying cause, that's when it gets to be defined as the chronic secondary pain syndrome. For example, pain that is happening despite the lack of evidence of increased inflammatory markers in juvenile idiopathic arthritis, or the pain in sickle cell patients that's happening without any evidence of sickle cell crisis. So basically, the pain diagnosis remains even after the underlying disease is no longer actively serving as the source of that initial noxious injury. And this chronic secondary pain syndrome is further divided into some other, at least 6 more subgroups. Those are chronic cancer-related pain, chronic neuropathic pain, chronic secondary visceral pain, chronic post-traumatic and post-surgical pain. And then there's the chronic secondary headache and orofacial pain. And last but not the least, chronic secondary musculoskeletal pain. And 2 of these actually deserve a little bit more dialogues. I mean, they're pretty self-explanatory, but let's talk about chronic cancer-related pain. It's defined as the pain that's caused by the cancer itself, either by the primary tumor or tumor progression, or even the metastases. Or it can be because of the treatment, which is surgical treatment or chemotherapy or radiation. All of those we know can result in neuropathic pain, chronic pain, various other pain syndromes. With improved survival rates, because of, we've made progress with creating successful treatment for all sorts of malignancies, and especially for pediatric cancer, chronic, albeit secondary pain syndrome like the neuropathic and musculoskeletal pain, they have become much more prevalent. So we see more and more, and that's why I wanted to call it out, because we have to be aware of these pain syndromes, either because of, just as a result of the cancer itself, or because of the treatments that we have applied. The other area that is also very important, and as a matter of fact, it's a prime candidate for prevention programs, is the chronic post-surgical and post-traumatic pain. This chronic post-surgical or post-traumatic pain is, again, it lasts longer than 3 months and beyond the normal determined healing times for whatever that surgical healing time is considered. So whatever that normal range of healing time is, if this persists beyond, and especially longer than 3 months, then it is considered as the chronic post-surgical or post-traumatic pain. And as I said just a minute ago, the chronic post-surgical pain is getting a lot of attention because there are things that we could do preventatively, that we can identify risk factors. There are risk factors that will tell us who is at risk for developing this pain, and then there are treatments that can be applied. There was a whole episode dedicated to this with Dr. Vidya Chidambaram, and I will link that in the show notes as well. And interestingly enough, the incidence of this pain is up to 30% of surgical cases. So it's not a minor thing. So we should really be identifying those at-risk patients or at-risk surgeries, then targeting that with appropriate treatments and interventions that may be able to help prevent development of this chronic post-surgical or chronic post-traumatic pain. Okay. So you may ask, why is it important to know what kind of pain it is, whether it's primary, whether it's secondary? Well, without understanding the nature of pain and trying to address the pain is like throwing spaghetti at the wall and seeing if anything sticks. You may get lucky with the spaghetti, or worst case scenario, you would just dirty the wall a little bit. But with this spaghetti approach applied to pain management, both you and your patients and their families have a lot to lose. You're risking all the consequences of untreated, undertreated pain that I've outlined in details in many of my episodes, and so have my guests. On the other hand, understanding these concepts better, understanding what's happening in the acute pain, what's happening in the chronic pain, and what kind of chronic pain is it, and at what point is it primary or is it secondary, and what point does it become secondary? and what the implication of that are. Those are the things that will help you eliminate the misconceptions for yourself, of course, but for those that you're caring for those that you're teaching. You will be able to help your patients and their caregivers understand their own pain, as well as increase their engagement in their treatments, because once they understand better, they'll be able to engage and participate much more actively. It provides them hope. It may help reduce the stigma that some of the cultures carry around what pain means to them. And we will also be doing another episode in the future about the biopsychosocial model of pain. Understanding this also will aid and improve access to appropriate multimodal treatments. And even the other governing bodies or policymakers or insurance companies will help in supporting the multimodal treatment models for this. And of course, all that would result in ensuring better outcomes for all involved. And last not but least, when we understand them accurately, we do better research, we find out more relevant information, and we just do better in general. So I hope in this episode, I've at least been able to advance some of your understanding of what acute versus chronic pain is. And within chronic pain, there is still distinction between chronic primary pain and chronic secondary pain. Now, as far as the treatments are concerned, let's address and tackle that in another upcoming episode, which we will talk about targets for pain control, and that will help you understand this even better. So continuing the theme of this Pain Awareness Month, I will bring that episode to you guys soon in this month itself. So with that, this brings me to the end of this episode. I do want to highlight that all our episodes are geared towards our goal here at Pedia Pain Focus is to consistently bring you pertinent practical information, education, and tools. The content is designed to enhance any clinician's repertoire in order to help them deliver not just appropriate, but really superior and excellent care for their pediatric pain patients. And if you happen to find yourself challenged by your patient's pain care needs, or you just want to jumpstart and advance your own or your team members' expertise with pain management issues even further than what you get from this podcast, then feel free to reach out to us. You can schedule a free call with us, and we have lots of other convenient resources that are specifically designed with busy practicing physicians in mind. And by the way, if you have any patients and families that need and you think can benefit from self-pain management resources, you should direct them to our website. There are lots of resources for them for free, specifically created and designed to support and empower these patients and these families who are affected by and suffering because of their pain. So for this week, folks, this is goodbye. I will see you next week. As a matter of fact, this episode is coming a little bit later than intended, so you'll actually hear me in just a few more days. I will be back here with the next episode that is Targets for Pain Control. So thank you for joining me again. Share this episode with someone you think might benefit from hearing this information. Thank you once again. Until then, be safe, be proactive. Bye now. Pedia Pain Focus is brought to you by Proactive Pain Solutions, a company committed to improving the lives of children affected by pain and the clinicians taking care of these children. Our mission is to ensure access to high-quality expert pain care for every child through innovation and in partnership with our empowered stakeholders, which is healthcare institutions, clinicians, and patients and families. Through our online education and consultation for clinicians and institutions, we're creating experts and leaders in the field, empowering patients and caregivers with the knowledge and tools for self-management, enabling them to live a functional life. If you wish to advance your pain care expertise, improve the operational performance of your pain care services, or you just want your patients and families to be more informed and active partners in their own care, please contact us at www.proactivepainsolutions.com.